Hi everyone, welcome back to the new topic, Obstetrical Triage. I am Dr. Beulah Dallas, HOD of Community Health Nursing Department. Obstetrical triage is the assessment and the prioritization of pregnant women seeking healthcare. It helps identify urgent maternal and the fetal conditions to treat immediately or diagnose immediately, ensures timely treatment and for safe outcomes of the delivery. The objective of this session is understand the concept of obstetrical triage, identify components of triage assessment, recognizing the priority levels, and improve the maternal and fetal safety. Obstetrical triage is a systematic process of evaluating pregnant women on arrival to determine urgency of care. This is commonly used in the labor and the emergency unit. What is the importance of this obstetrical triage? We can able to do early identification of complications in the fetal as well as in the mother. Efficient use of healthcare resources to treat to save the life of the mother and the baby. Reduces maternal and the neonatal morbidity and the mortality. Improve patients' flow in maternity unit. This is the obstetrical triage flow. When the patients arrive to the ward or the unit, we can do the initial assessment, then go with the vital signs and to check the fetal heartbeat and fetal well-being, then move on to the risk classifications based on this assessment, and based on this classifications we can do the management or treatment at the institutions, or if it is unable to manage in the situations, we can refer to them to the higher level referral system. This is the example of flow of triage. When the mother is coming to the ward, antenatal ward or in the labor ward by walking, she is normal. We can put her into category 3. Suppose if she is unable to walk, she is coming with the support on the stretcher or wheelchair, then we have to assess her breathing. If she is able to breathe normally, then we have to assess the respiratory rate. In respiratory rate is normal, that is between 10 to 30 breaths per minute, then we have to assess the circulations. In this breathing and respiratory rate and the circulations, if there are any alterations, there are any difficulties in breathing, and is there any abnormality in the respiratory rate or in the circulations, then according to that conditions we have to prioritize and we can put them into category 1 or 2. So that means we have to give more importance to the category 1, and the next level we can give importance to the priority category 2. So here the breathing, if there is no breathing, then it is declared as dead in order to do anything else. Suppose after doing the airway clearance, or if after the clearance airway opens, if she is able to breathe, means we can put her into category 1. That means we have to give more priority for this mother to give care. And when your respiratory rate is less than 10 or more than 30 breaths per minute, in that case we have to put her into category 1. That is, we have to give most priority to provide care. And if the respiratory rate is normal, we have to move on to the assess the circulations. In the circulations, here also, the less than 70 or more than 140 beats per minute of pulse. In that case, we have to put the mother into category 1. Suppose her pulse rate is 70 to 140. In that case, we can put her into category 2. So this is the way we can classify or the that is most priority care, and what is the next level, or if it is normal. Okay. So next, the common reasons why we have to follow this obstetrical triage in the ward or in the labor ward. So here we have to assess the labor pain. whether she is having this normal pain or any obstetrical labor will be happen. All those things we can able to assess, and we can provide appropriate care to the mother and the fetus. So next we have to assess for the vaginal bleeding, decreased fetal movement, hypertensive symptoms, and the rupture of membranes. In these all the cases, we have to assess and give priority based on the situations. In the initial assessment, what we have to do, as we have discussed in the flow of triage, first we have to check about the airway, breathing, and the circulations. And we have to measure the vital signs, assess the fetal heart rate, evaluate the pain and the contractions. So here is the maternal and fetal assessment flow. First, we have to check the airway and breathing, circulations, fetal heart rate, and the contractions. If you are having any abnormalities here, then based on that, the severity, we have to categorize into category 1, 2, 3. So under the maternal assessment, we have to check the blood pressure of the mother, we have to check the temperature of the mother, and pulse and respiratory rate, obstetrical history of the mother, current pregnancy, complaints. These are the things we have to give more important in the mother's side. So blood pressure, if she has high blood pressure, then we have to treat. Then temperature, if she has any fever, then maybe due to some sepsis or infections, in that case we have to treat the mother. Pulse and respirations, the rate is low or high, that to be treated. And then obstetrical history, the previous history, and this during the first and second trimester or third trimester, any other illness, any other fatal history, that we have to consider and treat based on that. And what is the current pregnancy compliance? Okay, that also we have to assess. So it will be easy for the healthcare team to provide proper care based on the categorizations with the help of this obstetrical triage. So under the fetal assessments, what we have to do here, we have to find out or assess the fetal heart rate. And ultrasound, if needed, we need to find out the position of the baby. We can the conditions, the movement, we can able to find out through the ultrasound. Assessment of the fetal movement, we can ask the mother, we can when we are doing the palpations, we can able to find out, or in the inspections we can able to find out, and through the ultrasound also we can able to find the fetal movement. Gestational age evaluations can be done. And here priority level, as we learned before, the immediate care, that is life-threatening conditions. If any abnormalities in the vital signs, or they having the high fever, or any problem with the fetal conditions or the fetal condition of the mother, that we have to give immediate care. That is the category 1. And the urgent, that is needs quick medical attention based on this vital and based on the present complaints. And the third priority, less urgent, that is able to manage that case, and non-urgent, that is in case of death. In that case, we are not to urge for anything else. So in the emergency conditions, here the severe vaginal bleeding will, and the eclampsia, fetal distress, cord prolapse, severe abdominal pain. The presence conditions, if they are having any kind of this problem, then we have to put them into category 1. That is immediate attention is needed for the mother and the fetus. So how we can assess this labor? Frequency and duration of contractions. Okay, then the cervical dilatations. So frequency and duration of contraction and all, we have to observe, and we have to record it in the partograph. And the cervical dilatation, rupture of membranes, fetal positions, all those things we can we have use the partograph. Through that we can be able to find out whether that labor will be happen in the in the right durations, or it will be a obstetric labor or any other complications is occur that can be observed by assessing this. These are the conditions during the labor. Then the diagnostic test. So what are the diagnostic tests we can do? Non-stress test, ultrasound, blood test, and the urine analysis. Mainly in the urine analysis is albumin, sugar and albumin. This is the obstetrical triage wrist bandaging. Here we have three colors: red, yellow, and the green. Green means normal, and the yellow we can have the less attention, and red we have to give more attention. Immediately we have to provide the care to the mother and the child. So what are the conditions comes under this red banding? Eclampsia, seizure, severe preeclampsia, severe antepartum or postpartum hemorrhage, coma or unconscious, abnormal vital signs, and the serious maternal conditions like diabetic ketoacidosis, sickle cell crisis, severe asthma, pulmonary edema, and 2 or more previous LSAs in active labor, grade 3 meconium liquor, persistent fetal bradycardia, severe abdominal pain or heavy bleeding at less than 24 weeks of the gestations. And under this yellow banding, here the sickle cell not in crisis, decreased or no fetal movement, multiple pregnancy or breach in labor, preterm rupture of membrane, stable or managed hypertension, previous cesarean, diabetic and other medical conditions, HIV positive mother, early pregnancy problems, that is less than 24 weeks. And this green bandage, it's a normal labor. There is no generalized complaints during the arrival of the mother to the labor ward. So this is the way we can classify or banding, that is provide the risk banding. Through that we can identify their priority of care. And here we have some of the conditions. Here the critical conditions like this that need some life-saving treatment. Here status instability, that is in the breathing or mother is unconscious, and seizure, trauma or fall, blunt trauma, severe vaginal bleeding, that is the clot excretions, immediate childbirth, severe headache, blurry vision, feeling of umbilical cord prolapse by mother, no fetal movement above 25 weeks, tetanic uterus, severe and persistent pain at gestational age over 24 weeks, vaginal discharge, chest pain less than 12 hours, and unilateral swelling and pain in the legs and thigh, bruising of the limbs. Urgent within 1 hour. Here fever, lethargic, panic, confusion, self-harm, harassment, suicide decisions, dyspnea less than 24 hours, heavy bleeding, headache with aura symptoms, nausea and diarrhea with diabetes, epigastric pain with nausea and upper abdominal contractions or pain under 24 weeks, epigastric pain with nausea and upper abdominal contractions and severe pain under 24 weeks, chest pain over 12 hours, referral pain to the shoulders. Here the less urgent, within 4 hours we can treat pruritus, uncontrolled pregnancy, mild vaginal bleeding over 16 weeks, stress and the anxiety, emotional problems in the last 24 hours, or a headache with lack of movement above 20 weeks and under 24 weeks, pain and gestational age under 24 and over 37 weeks, vaginal color discharge, persistent nausea or diarrhea, constipation, stomach pain, pleural pain, problems in the extremities, limb or backache. There is no urgent, within 24 hours we can treat. What are the cases here? Unapproved pregnancy with ultrasound above 5 and under 16 weeks and scanty vaginal bleeding, dental oral problems, that is oral abscess or gingivitis and dysuria. So here the recommendations are ultrasound confirmations or uterine pregnancy and bleeding, lack of fetal movement less than 2 hours, headache without aura, absence of fetal movement under 20 weeks, simple swelling, pregnancy morning sickness, mild diarrhea less than 16 weeks and hemorrhoids, pelvic girdle pain. So these are the conditions we can treat as the normal symptoms during the pregnancy. So what is the role of the nurse by doing this obstetrical triage? So rapid patient assessment is very important. Based on the category, she need to know how to categorize the uh, mother. Then monitoring maternal and the fetal conditions, communications with the obstetrical team, documentation of findings. So these are the main role of a nurse while doing this, categorizing the obstetrical cases. Then documentation, it's a very important thing. Here the record time of arrival, when the mother is entered into the ward, what was the conditions, all those things should be documented. The vital signs especially. So here the pulse and respiration, blood pressure, that is playing a main role, and the symptoms and findings, interventions performed during when they are arriving and during the stay of the labor ward or in the ward. So some of the challenges also is there while practicing this triage. That is high patients volume, limited staff, delayed referrals, lack of standardized protocols. So high patients volume, sometimes limited staffs will be there, but at a time that patients more patients will be comes. In that case, it is difficult to do the triage and do the management to the mother and the fetus. And the delayed referral. So slowly, if you are doing everything, and in case of giving more attention, immediate attentions, here we have failed to refer the cases also maybe happen. And the lack of standardized protocols, already the standard protocols will be there, but for the practicing of that protocol, sometimes it may be missed. How we can promote this obstetrical triage? We have to provide good training to the staff, how to classify the how to categorizing the obstetrical conditions, and how to treat, what are the first aid they have to do, when they have to refer, how to assess, what are the initial assessment that is needed, and all those things we have to give a proper training to the staff, those who are appointed in the labor ward or in the antenatal ward and postnatal ward. And the use of triage protocols, they have to train them, and we have to monitor the people to follow this triage of protocols. And the electronic health record need to be maintained, continuous monitoring system, that is very essential for the successful of this obstetrical triage. Let me conclude this topic. This obstetrical triage is essential for maternal and fetal safety to reduce the morbidity and mortality among the mother and the child, mainly in the fetus. Proper assessment and the prioritizations will be saving the life of the mother and the fetus. Effective treatment that will be improves the outcome of the services. Thank you for your patient listening.